So just to give everyone a heads up, this webinar is being recorded and we will post it to our YouTube and disseminate it out to everyone after today's webinar. We'll go ahead and jump in now. Today, we're going to talk about more about SB 326, which is the MHSA modernization, changing the MHSA to the Behavioral Health Services Act. And by specific request at one of our prior webinars, we are covering the topic today, the stakeholder involvement changes. So like around the community program planning process that's in the current MHSA, we're looking at how SB 326 would change those requirements. So a little bit about ourselves. So I'm Danielle Zavala. I'm the Associate Director here at Cal Voices. I've worked here for approximately 11 years now. My role is really just to help my boss, Susan Gallagher, run the organization, wear a lot of hats. I identify as a consumer of mental health services. And I think we're just trying to keep the fort tied down right now with all of these changes that are in the wind. And joining me today again is Claire. Do you want to go ahead and introduce yourself?
Hi, sure. My name's Claire Courtwright. I'm the policy director with Cal Voices, so focusing on legislation for the organization, legal analysis. I'm an attorney and I am a consumer and peer, and happy to have you all here again.
Thank you. So a few housekeeping things. The webinar is scheduled again for 1.5 hours. I've tried to condense some of the content to just talk about some of the main points. I did include additional content in the webinar that we may not get to, but everyone will get the slides from today's PowerPoint. So if you want more specific detail, if we don't have a chance to get into specific details because I'm trying to be mindful of everyone's time, you will still get that information when we disseminate the PowerPoint slides. As I mentioned at the beginning, this webinar is being recorded. The recording and the chat log, we'll go ahead and make it public and disseminate it to everyone. Closed captions are currently turned on for those who require them. Everyone right now is currently muted. So if you raise your hand, we can call on you and unmute you. Until then, everyone's going to remain muted. We will pause regularly for questions and feedback. So raise your hand if you want to talk and we'll unmute you. And then you can add your comments to the chat box at any time. So a few ground rules. So honor yourself during the webinar. As I mentioned, in our first webinar, the topics and the things that we're talking about can be kind of personal. We really hold the Mental Health Services Act in high regard. It was, a stakeholder-driven legislation. And so it does feel very personal sometimes when these changes are being discussed. So practice self-care. If you need to get up, walk around, get a drink of water, whatever, it's totally okay. Model the behaviors that you want to see in others. And honor your fellow human beings on the webinar. So assume good intent. Sometimes things don't always come out right when we say things, myself included. I tend to be expedient and say things in the fastest way possible and not always the kindest way possible, although that's not my intent. Focus on the issues and the facts, not individual people. Look for areas of alignment. If you want to disagree, you're welcome to do so, but please do so respectfully. Try to offer solutions and suggestions. And then if you can, keep your questions and comments brief because I don't know how much time we will have and I want to make sure that everyone has an opportunity to share. So today we are talking about session 3, the Behavioral Health Services Act, focusing on the changes to the community program planning process. We had previous, the captions are kind of, for me on my screen, the captions are covering part of the PowerPoint. So I'm just going to try to not see them right now. Hopefully everyone else is able to see them still. Yes? Can everyone still see the closed captions? Okay, just making sure. Great. So today we're, again, like I mentioned, we're going to be talking about the MHSA's community program planning process and the changes that are being implemented by the Behavioral Health Services Act, or SB 326, to this process. Our previous webinars focused on overall changes to the MHSA's current program and expenditure components, and then also housing components in the MHSA, how this new legislation is going to be changing that. So we'll go ahead and get started. The agenda is pretty short for today, but the conversation will probably be very dense. So in section 1 of this webinar, we're going to talk about SB 326's legislative updates. There are recent amendments that were just published last week. And so, part of this is we were trying to scramble to make sure that we covered, the main highlights. So we have some updates there. We're going to talk about the MHSA's current stakeholder involvement requirements around, the local planning process, community program planning, and what they look like right now. And then we're going to talk about SB 326's stakeholder involvement requirements and how they're different and similar to what's currently in the MHSA. So a few important disclaimers. We've said this before, we're a peer-run organization. We've been working in the public behavioral health system for over 40 years. So the positions and priorities that we take are informed by our organizational experience and our core agency values, which are aligned with the recovery model and the goals of the consumer movement. So this webinar reflects our perspectives on pending legislative efforts to modernize the MHSA. Your views and concerns might be different from ours, but we welcome the conversation. Again, this is about SB 326. The full legislative language of SB 326 was only released in June. So we have had only about 2 months to try to absorb some of this information. And as I mentioned, major updates were rolled out last week on August 15th. So we're also trying to digest that information. So we have not had an opportunity yet to fully analyze all of the bill's potential impacts on the MHSA, on clients, and on peers. So we're focusing narrowly right now on how SB 326 alters the MHSA's current stakeholder involvement mandates, but we're not exploring all the ways in which SB 326 will change the MHSA. Again, information is constantly being updated. We will keep you informed as new information comes out, and we'll try to stay on top of this to the best of our ability. If you want the original sources of any of the factual information, I've tried to include citations to existing MHSA statutes and regulations in this PowerPoint presentation. But if you want us to provide additional backup, citations or sources for any of the factual information in this webinar, you can shoot Claire an email and she will respond to you and provide that information, or I can do that as well. If possible, try to identify the slide number that you want the information from. So any questions before we begin? I see Mark has his hand up. It's been up since the beginning of the webinar though, so I don't know if it was an accident or if it was intentional. So I've unmuted.
Like Mark is asking for the phone in order to get in. And
oh, okay.
Because he did not have a microphone.
Got it. Okay. So Steph, you're able to do that? Okay, Steph will send that information or put it in the chat box.
Okay, thank you.
And Richard Gallo, I see in the webinar chat, is the CPP part of the Mental Health Services Modernization Act? So yes, sort of. We'll get into that. Any other questions or comments before we begin? Okay. So again, the agenda, first we're going to talk about legislative updates that came out last week. Then we'll talk about the MHSA stakeholder involvement requirements, and then SB 326's stakeholder involvement requirements. And I'm going to turn it over to Claire. Claire, you can just let me know what you want me to do the next slide, and then I'll progress it for you.
Sounds good. So as Danielle mentioned, amendments were released on August 15th, so quite recently, and we'll cover some of the main ones, but we haven't had time to really go through. They're fairly extensive. So just a little background, SB 326 was originally a spot bill, meaning it had some language in it about federal participation, but that was it. It really didn't have this extensive amendments to the MHSA originally. So it kind of went through the first house, which was the Senate, with none of these extensive amendments. And then when it made it into the assembly on June 19th, that's when all the language was actually dropped. Since that language was dropped in mid-July, the Assembly Health Committee, which is where the bill is currently pending, voted to adopt an urgency. And what that means is that if the legislature passes this, it will take effect immediately. And that was necessary to get it done soon enough to be on the March ballot, which is what they want. So at this point, the only votes that have happened in the assembly was really to adopt that urgency, that the bill would take effect immediately. It is currently pending for an actual vote onto the substance of the law before the Assembly Health Committee, and that is going to be tomorrow on the 22nd. There is an informational hearing in the morning that isn't the official legislative body's action. That action will be at a second hearing in the afternoon. And it's grease lightning because if the legislature chooses to adopt this language to place it on the ballot, the final deadline to vote in both the Assembly and the Senate is going to be September 14th. Because all these amendments were introduced after it got out of the first House, which was the Senate, it does have to go back at least for a vote in the Senate. And then, if the Senate and Assembly pass it, and it does need to be passed by 2/3, then it will go on that finalized language will go on the March 2024 ballot, because voters have to adopt major changes to the MHSA. Next slide, please. So some of the major amendments from last week were to reduce the Behavioral Health Services Act revenue. So all that tax revenue that gets collected, a certain percentage is going to the counties. And it changed the percentage going to the counties down to 90%. And that happened because the population-based prevention piece of it was removed from the counties and placed into the hands of the state. So that was the big shift there. Another clarification was previously the bill had said that Behavioral Health Services Act funds, the counties had to provide substance use disorder services with those funds. So it was a mandate to provide substance use. They changed that to permissive. The counties can provide substance use services with this money. They are no longer mandated to do that. It also added non-supplant mandate for SUD services. So the non-supplant is basically just says that you're not allowed to use the money for some other than the specified purpose. And previously it had only said mental health services in the non-supplant language. They added substance use disorder services. Again, I mentioned population-based prevention, which was taken out of PEI. So it was prevention, early intervention in the original MHSA, and they took the P out. So P is now stands for population-based prevention, and that was moved to CDPH. It also expanded, the amendments expanded behavioral health services and supports, permitted spending to include outreach and engagement, which is in the original MHSA, and that language had come out and now it has gone back in, that the counties are permitted to spend on outreach and engagement activities. Next slide, please. So here's just the pie chart of how this is going to be broken out now with the amendments. So state agencies are going to get 3%, workforce 3%, and population-based prevention 4%, which will leave the counties with 90%. There was also some tweaks in the language. So previously, for instance, the workforce initiative said it shall be no more than 3%. They changed that to say a minimum of 3%. So how sticky are these numbers? This 3, 3, and 4, can they actually go up some? That's a good question. But this is how DHCS has expressed their changes as well. And that's what's in the bill language, except for the change to language of it's a minimum of 3%, et cetera. Next slide, please. So this is how that 90% that's going to the counties is redistributed. The big change here is that behavioral health services and supports went from a 30% allocation to a 35% allocation. And again, that population-based prevention came out. So this is the general schema of allocations now. Next slide, please. So here it is with a little more expansively. So another change from the amendments is that early intervention. So a majority of behavioral health services support allocation has to go to early intervention, and they created a new mandate within early intervention that half of the early intervention funds have to go to services for persons 25 years old or younger. The other allocations are basically the same. Half of the housing interventions allocation has to go to persons who are chronically unhoused with a focus on encampments. There are still these permissive nibbles out of these allocations for community planning process, QA, QI, and other costs that aren't strictly service related. And then the FSP 35% allocation remained the same. That was not changed. Next slide, please. So that's the extent to which we've looked at their amendments. They were mostly in the allocation of funds section of the MHSA. There's a lot more to look at here that we just haven't had time to look at yet. And I imagine that we will, when the dust settles on this, because the final language has to be approved by September 14th. So then there's going to need to be some analysis of what this is when all the amending is done and what it's going to be before it goes on the March ballot. So we expect to do additional analysis and have a better sense of everything that got amended on the 15th and everything that might still get amended going forward. So if you sign up for our mailing list, you will get any updates from us concerning additional analysis. You can also track the bill independently on the Leg Info site, which will tell you, votes, what committee it's pending before, hearing dates, all that kind of information. If you want to independently track it, which is a good idea, you can do that on Leg Info. And we're also looking out for the LAO. The Legislative Analyst's Office really has done some of the best kind of analysis of this. And they plan to apparently do more in their series on MHSA modernization. So you can look out for that independently too on the LAO's website, and the link is there. And I think that wraps it up for me.
The other thing too is if you want to contact your assembly member or your state senator to provide your feedback, you can always look up, if you don't know who they are already, you can always look them up at this website here, findyourrep.legislature.ca.gov. We have a sample letter. We'll probably be updating that sample letter that you can use, and you can add or change language to it, whatever you feel comfortable with. And then also, if you'd like to attend tomorrow's hearing in the Assembly Health Committee, we are setting aside stipends for anyone who shows up. We have shirts that say no on SB 326. You may or may not want one of those shirts, but if you show up and wear one, we would be happy to pay a stipend for you to provide your public comment and feedback. So we have a few minutes for questions and discussions before we move on to the main meat of today's webinar. It looks like Jude has their hand raised. I've unmuted you, Jude.
Oh, sorry, I don't think I plan to do that.
Oh, okay. I'm going to go ahead and remute you, and I'm going to put your hand down here. Mark, your hand is up. You should be able to unmute yourself if that was intentional and you wanted to talk. All right. Go ahead, Mark. You'll need to unmute yourself. if you want to say something. Okay, I'm going to go ahead and, all right, looks like you lowered your hand. All right, we're going to go ahead and move forward now. So we're going to talk about the MHSA's requirements for local stakeholder and local and state level stakeholder involvement. So I mentioned this before in our previous webinars. The MHSA was passed through Proposition 63, which was a grassroots stakeholder ballot initiative that established the Mental Health Services Act. Again, it was passed by California voters in November of 2004, so almost 20 years ago. It was originally drafted by Darrell Steinberg, now the mayor of Sacramento, but at the time he was a California Assembly member, and Rusty Seelix, who was the executive director of Mental Health America of California, with mental health consumers, family members, peers, providers, advocates, and other key stakeholders. So even though Darrell Steinberg was a member of the assembly at the time, it was actually a grassroots, it was not a legislative ballot initiative. It was actually a grassroots stakeholder ballot initiative that got the MHSA passed. It created a 1% tax on personal incomes over $1 million to expand mental health services, including services that were not already reimbursable under Medi-Cal, and to transform California's public mental health system. So in this particular webinar, we get into some of the statutes because everybody knows about the community program planning process, or many people know about the community program planning process, but where the requirements are laid out are kind of scattered throughout the existing MHSA statutes and the current MHSA regulations, okay? And it matters because when the statutes are updated, it's unclear what the status of prior regulations that were interpreting those statutes. It's unclear what the status of those regulations will be. So they may not be automatically voided out when statutes are updated, but a lot of the community program planning process is in the regulations. And so even if statutory language is updated, we don't know what's going to happen to those regs. So just a quick primer. So the legislature passes statutes, right? We often refer to them as laws that once signed by the governor are implemented and enforced by state agencies. The state agencies who are responsible for the statutory implementation and enforcement develop regulations or regs to interpret the statutes and govern how they're operationalized. Now, because state agencies' authority to write regulations is derived from the statutes themselves, the words and the practical effects of the regulations cannot directly contradict the intent or plain language of the statutes that the regulations are interpreting or operationalizing. So that was a mouthful. It basically just means that regulations can't contradict statutes. Statutes are higher in the hierarchy than regulations. So if passed by voters, SB 326 will change most of the existing statutes that collectively make up the MHSA. The impacts of these changes on the existing MHSA regs is unclear. So as I mentioned, the existing MHSA regs that directly contradict any new statutory language or intent would likely become unenforceable, even if they're not actively repealed or rewritten, okay? They could just kind of sit on the books without anything being done. Other MHSA regulations like the general standards, the regulations that deal with the CPP process or the community program planning process, and most of the definitions that currently define terms in the MHSA, those those regulations might remain in effect unless or until they're actively repealed or rewritten. So a lot of this is still up in the air. You'll see, I'll cut to the chase here. You'll see throughout this presentation that we've cited, where part of it is citing to the current Welfare and Institutions Code. You'll see on the slide itself, Welfare and Institution Code, and where it's citing to the current California Code of Regulations, it'll say 9 CCR, and it'll have the little section symbol, and it'll tell you where we're getting this information from. So let's talk about the MHSA's current state level stakeholder involvement requirements. So just a quick review, the MHSA created a 1% tax on personal incomes over $1 million. That money is held by the state in the Mental Health Services Fund. Before allocating funds to the counties, 5% of all of those funds is reserved for state agencies, the state agencies that have responsibility for implementing and enforcing the MHSA. So again, currently the way that's broken down is the 5% goes to state agencies and 95% goes to counties. So let's talk about state agencies' requirements to include stakeholders. These are all the various state agencies that currently have responsibilities to enforce some portion of the MHSA, DHCS or Department of Healthcare Services, the Mental Health Services Oversight and Accountability Commission, MHSOAC, the California Behavioral Health Planning Council, the California Office of Healthcare Access and Information, or HCI, it used to be known as OSHPD. They implement the state's 5-year MHSA WET plans. And then also California Department of Public Health administers some programs to reduce mental health disparities. So again, prior to sending out that 95% of MHSA funding to the counties, 5% is reserved for state agencies. Part of these administrative costs shall include funds to assist consumers and family members to ensure the appropriate state and county agencies give full consideration to concerns about quality, structure of delivery, service delivery, and access to services, right? So there's this nebulous requirement that's in the statute right now that these state agencies that receive MHSA funding need to use some of that funding to include consumers and family members in their decision-making. So what are some specific requirements under the MHSA right now around stakeholder involvement? So currently the MHSOAC has 16 voting members, and those 16 voting members must include at least 2 persons with mental illness or severe mental illness, SMI, one family member of an adult or a senior with SMI, and 1 family member of a child with SMI. So basically there's 4 seats right now on the MHSOAC that must be filled by a client or a family member. In making other appointments to the MHSOAC, the governor shall seek individuals who have had personal or family experience with mental illness. So in the non-consumer and family member seats on the MHSOAC that the governor appoints, people who have personal lived experience are prioritized. The MHSOAC shall ensure that the perspective and participation of diverse community members reflective of California populations and others suffering from severe mental illness and their family members is a significant factor in all decisions and recommendations. So again, it doesn't say how the MHSOAC has to implement this requirement, but there is a requirement that the commission include the perspectives of diverse communities, consumers, and family members in their decision-making. So there are also some specific requirements in the current MHSA around the Behavioral Health Planning Council and the Office of Healthcare Access and Information. So the Behavioral Health Planning Council and HCI are responsible jointly for developing and then also implementing the state's 5-year MHSA WET or workforce education and training programs. So when they're doing that, when they're implementing and developing the state's workforce education and training plan, they are supposed to include promotion of the employment of mental health consumers and family members in the mental health system, include promotion of the meaningful inclusion of mental health consumers and family members and incorporating their viewpoints and experiences in the statewide, workforce education and training programs. And then also promotion of meaningful inclusion of diverse racial and ethnic community members who are underrepresented in the mental health provider network. So just a quick pause here. So what I'm trying to do is show you all of the different areas right now in the MHSA and in the MHSA regs where it specifically spells out that stakeholder involvement is required. It's very hard to find all of these and put them all together. So it's sort of like putting a puzzle together where all the pieces came from different boxes. So I hope that it's not too confusing. If anyone has any questions, we will pause after this next section and get to those questions. So now let's talk about MHSA local level stakeholder involvement requirements. Okay, we already talked about this. Okay, so you have here, the counties currently get 95% of all MHSA revenues, and they have to spend those revenues on prevention, early intervention, innovative programs, and community services and supports, among other things, right? So this is the current breakdown. There are layers of stakeholder involvement required, right? So the MHSA currently requires meaningful stakeholder involvement in all aspects of local mental health decision-making. These requirements are articulated in statutes and regulations that govern the MHSA's general standards, the community program planning process and 3-year plans and annual updates, and the local review process, which is all part of that. And then also for local mental health boards who have a role in the local review process. So I kind of look at it like this, right? There's supposed to be stakeholder involvement at all levels within the public mental health system. Often counties establish standing MHSA advisory bodies to participate in their local community program planning process. So often they'll call them like MHSA steering committees or like community campaigns or leadership teams that deal specifically with planning and stakeholder engagement for MHSA programs and services. So stakeholder involvement is infused throughout the MHSA's general standards. So counties are required to adopt the MHSA 6 general standards in planning, implementing, and evaluating all programs and services funded by the MHSA. This includes, the general standards being infused in the community program planning process, development of counties' 3-year program and expenditure plans and updates, and the manner in which counties deliver services and evaluate service delivery. So why does this matter? Well, because the general standards specifically include requirements around stakeholder involvement. So community collaboration, cultural competence, client-driven adult services, family-driven children's services, services that are wellness, recovery, and resilience focused, and integrated services experience for clients and families. Now, all of these general standards include layers of stakeholder involvement. So community collaboration is a process by which clients and or families who are receiving services and other community members and agencies and organizations and businesses work together to share information and resources in order to fulfill a shared vision and goals. So the MHSA requires everyone to get together, develop a shared vision, and provide their feedback and input around how programs and services are created and funded. Cultural competence, it requires services to be culturally competent. I include this as stakeholder involvement because you need to ensure that people who are representing diverse communities, especially traditionally underserved and marginalized communities, are participating in decision making, because you will not have a culturally competent system if you do not have people who are representing diverse communities involved. Services need to be client driven. So when we're talking about the levels of stakeholder involvement, it's even down to the individual services level where stakeholder involvement is required. So client driven services mean that the client has a primary decision-making role in identifying their own needs, preferences, and strengths, and a shared decision-making role in determining the services and supports that are most effective and helpful for them. Client-driven programs and services use clients' input as the main factor for planning, policies, procedures, service delivery, evaluation, and the definition and determination of outcomes. So client-driven requires stakeholder involvement. Same with family-driven. It means that the families of children and youth with serious emotional disturbance have a primary decision-making role in the care of their own children. So again, family-driven means you have stakeholder involvement on the services level, not just on the planning level, not just on the budget level, but on the individual services level. Family-driven programs and services use the input of families as the main factor for planning, policies, procedures, etc. Wellness, recovery, and resilience focus, right? Okay, so this refers to adult mental health services and how those services are designed and delivered. So under the MHSA, planning for adult services shall be consistent with the philosophy, principles, and practices of the recovery vision for mental health consumers. So the recovery vision promotes and emphasizes personal empowerment, respect, social connections, self-responsibility, and self-determination. Again, stakeholder involvement on the services level. It promotes consumer-operated services like peer support and peer-run programs as a way to support recovery. Services reflect the cultural, ethnic, and racial diversity of mental health consumers, and services plan for each consumer's individual needs. So I left out the integrated services experience. I just realized that. Sorry, guys. So as you can see, the MHSA requires these general. Oh, I didn't actually. Sorry, I'm all over the place. I had a long weekend preparing this. I apologize. So there's also there's also requirements in the general service standards for adults that requires clients to be the #1 decision maker in their care. So general service standards for adults and older adults shall include provision for family support and consultation, peer support, et cetera, where it's appropriate for the individual, but also provision for services to be client directed and that employ psychosocial rehabilitation and recovery principles. Clients' individual personal service plans shall be designed to enable clients to self-manage their illness and exert as much control as possible over their day-to-day lives and long-term decisions. Integrated service experience. Sorry, I forgot I had this in here. It means the client, and when appropriate, the client's family have access to a full range of services that are appropriate for their needs. So the key takeaways on the MHSA's current general standards, they were developed to transform California's public behavioral health system from a fail-first model to a help-first model, not to necessarily maximize federal financial participation or drawdown of other matching funds, or to provide more money to do the same old things. The general standards incorporate stakeholder involvement into all MHSA funded programs, services, and activities. So it's not just the community planning process, it's how services are delivered. It's which services clients want. It's providing clients with voice and choice, and families and voice and choice in the services that they're receiving. If counties are able to consistently implement, monitor, measure, and adjust MHSA funded activities to fully align with these general standards, then the public behavioral health system would be transformed as the MHSA intended. So we don't necessarily know what SB 326 statutory changes, what the effects might be on these existing general standards. We don't know if it will change those standards automatically, if they'll be need to be rewritten or what, but presumably, if they stay in place, we don't know how that will interact with the new language of SB 326, which is more of a top-down approach to behavioral health services. So now let's talk about the MHSA's specific requirements around the community program planning process, or CPP process. So what's the community program planning process? So each county mental health program is required to prepare and submit a 3-year plan and annual updates for all of their MHSA programs and expenditures. So everything that they want to spend MHSA funding on, all the programs that they're going to provide through the MHSA, they have to create a 3-year plan and update that plan every year. The county shall provide for a community program planning process as the basis for developing their 3-year plans and annual updates. So again, you have this pie chart of all the MHSA funding that counties currently receive. And the question is, how are they going to spend it? They know that they have these individual buckets that they need to, provide programs and services within, but exactly which programs and services they're going to fund using these buckets, that's where the community program planning process comes in. So 3-year plans, again, are based on the county's available MHSA funding, and they also have to be established based on the MHSA's stakeholder engagement and planning requirements. And again, counties update their 3-year plans each year, and stakeholder involvement is required each year when those plans are updated. So they have to include programs for PEI, et cetera. Okay, so here we go into the real nitty gritty. So each 3-year plan and annual update shall be developed with local stakeholders, including adults and seniors with severe mental illness, families of children, adults and seniors with, families of children, adults, and seniors with severe mental illness, providers, law enforcement agencies, etc. So all of these stakeholder interests need to be represented in developing each 3-year plan and annual update. Counties must demonstrate a partnership with constituents and stakeholders throughout the process that includes meaningful stakeholder involvement on all of the following. So it's not just, hey, what programs do you want to see? You know, are these programs and services working for you? Stakeholder involvement is required in all decisions related to mental health policy, program planning, program implementation. So how programs are implemented, you know, who is doing the implementation, monitoring, quality improvement, evaluation, and also budget allocations. So it's not just what programs they want, it's like every aspect of how these programs are rolled out and evaluated. So the community program planning process, it means the process that counties use to develop their 3-year plans and annual updates in partnership with stakeholders to identify community issues related to mental illness, lack of funding, gaps in services, et cetera, to analyze the mental health needs of the community and to identify and reevaluate priorities and strategies to meet those mental health needs. So it's not just funding the same things over and over and over again because we've always done it this way. It's also looking at what the outcomes are and whether they're working and whether the strategies that we initially implemented are working. Because if not, then the community should have a say in how those programs and strategies should be changed. So what are some mandatory elements of the community program planning process? The county has to, 1, clearly designate a person who is responsible for the process within the county and adequately staffed the CPP process so that it is successful and inclusive. The process must include consumers with SMI or SED and their family members. It must be comprehensive and representative, and it has to provide training for county staff and stakeholders who are involved in the process. So these elements must be included in all CPP processes. So again, the counties need to designate somebody responsible. There has to be one person at least in the county who is responsible for the CPP process. Usually that's the MHSA coordinator. So they are responsible for the overall process and coordination and management of the process. There has to be consumer and family member inclusion in the CPP process. So not only must counties designate people who are in charge of the overall CPP, they also have to do the work of engaging and conducting outreach to the community to ensure that clients and their families have an opportunity to participate. And the CPP process must, at a minimum, include the involvement of clients and families in all aspects of the process, okay? So again, going back to the language around meaningful stakeholder involvement in mental health policy, program planning, implementation, et cetera, it's not just the planning process, it's the planning rollout, it's the evaluation, it's who works in the programs, it's what positions are being developed to be more inclusive and recovery oriented. I'm going to skip this. So the community program planning process has to be comprehensive and representative. So it has to, counties need to ensure that stakeholders who reflect the diversity and demographics of the county, including geographic location, age, gender, and race and ethnicity, participate in the CPP process. So if your county has some urban areas and rural areas, the CPP process needs to include people from both of those geographic locations within the county. It needs to, ensure that if you have a high population of, immigrants from a certain country or community, that they're included as well if they're receiving services. So it needs to be very expansive and inclusive. So in addition to consumers and families, the MHSA also requires participation of additional stakeholders. So service providers, law enforcement agencies, education, social services, et cetera. It also, in the original instructions issued by the Department of Mental Health for the community program planning process, it also included peers. Peers needed to be involved in the community program planning process. And then finally, the CPP also has to include county and stakeholder training. So the CPP process at a minimum must include training for county staff who are designated responsible for the CPP functions, and then also stakeholder training. So training for stakeholders, clients, and when appropriate, the client's family who are actually participating in the process, because you can't have meaningful stakeholder involvement if stakeholders don't have the information that they need to provide meaningful feedback. So the Department of Mental Health, back again when the MHSA was first being rolled out, they provided some guidance around what needed to be included in those county and stakeholder training. So they said the training content should include background on the public mental health system, systems of care in the MHSA, concepts of recovery and resiliency, cultural competence, the county's underserved and unserved communities, and the elimination of racial and ethnic disparities, county specific data and information around who the target client populations were, how to hold a successful and interactive public hearing, how to make systems changes, and then background on consumer and family operated services. So all of this was supposed to be in the training provided for folks who are participating in the CPP process. So there are also some mandates around county compliance with the MHSA's CPP requirements. So county's 3-year plans and annual updates shall include certification by the county mental health director, which ensures that the counties complied with all pertinent regulations, laws, and statutes, including stakeholder participation requirements. Counties' MHSA programs and services shall only be funded if the CPP process was followed. And then counties' 3-year plans and annual updates shall include a statement explaining how the CPP requirements were met. The MHSA includes funding for the costs associated with the CPP process. So counties' MHSA programs and their 3-year plans, basically in their annual updates, have to include funding allocations for annual planning costs. These costs shall not exceed 5% of the county's total MHSA revenues. The planning costs must include funds for county mental health programs to pay for the costs of consumers and family members and other stakeholders to participate. But note, although counties are able to spend up to 5% of their total MHSA revenues on the community program planning process or stakeholder involvement, most counties allocate less than 1% to this process. And then finally, once the plan is approved or the annual update is approved, it goes through what's called the local review process. So counties circulate the draft plan to representatives of stakeholder interests and other parties who want a copy of the draft plan. There's a 30-day public comment period. The local mental health board or commission holds a public hearing on the 3-year plan. Community members, stakeholders, and members of the local mental health board can provide substantive recommendations to the county on changes to the plan. Eventually, those changes may or may not be incorporated into the final 3-year plan or the final annual update, but those recommendations need to be included in the final plan, even though they may not be changed. And then the Board of Supervisors approves it, and it gets sent to the state, to the MHSOAC, and to the Department of Healthcare Services for final review. So this is essentially the MHSA's current stakeholder involvement cycle, right? The MHSA annual stakeholder planning process. It's an ongoing process. It includes the community program planning process, development of the draft 3-year plan or annual update, the local review process, and then it goes on to the final 3-year plan update and then submission to the state. But all along this is ongoing activities that are involved. This is an annual process because annual plans are constantly being submitted by counties. And it involves front-end stakeholder involvement around mental health policy, program planning, and budget allocations. And then also back-end stakeholder involvement around implementation, monitoring, quality improvement, and evaluation. So this is the idealized version of stakeholder involvement through the MHSA. So key takeaways from this section, the CPP process is the mechanism by which counties develop their 3-year plans and annual updates for all MHSA programs. The MHSA stakeholder inclusion mandates are all encompassing and go far beyond just annual planning activities. The MHSA requires meaningful client and family involvement in all aspects of local mental health decision-making, as well as MHSA program implementation, monitoring, quality improvement, and evaluation. So the bottom line is the CPP process requires ongoing year-round effort. This is the current status of the stakeholder involvement under the MHSA. So I spoke a lot. That was a lot of information. Are there any questions right now about the current stakeholder involvement requirements under the MHSA before we start to delve into the changes? Mark, you should be able to talk. I think you can unmute yourself. I don't know if, okay. Richard Gallo. Go ahead, Richard.
Yeah, I think everyone's not aware that they can file a complaint with the county or with the Board of Supervisors or with the Department of Healthcare Services when these policies are not being followed with the CPP process. You have a lot of county behavioral health directors who don't have their buy-in with this process, and they haven't been. So the more complaints, the better that the state will recognize that this is a problem, that this has been an ongoing issue. You know, I informed verbally during public comments with the Oversight Commission, but turn on deaf ears. It's all about accountability, and there is no accountability.
Yeah. Any
I'm
other
done.
questions? Oh, okay. Thank you, Richard. No, I totally agree. It's really hard when there's not consistent leadership, and that even, you know, giving folks the benefit of the doubt, not all counties know the origins of the MHSA. They're not always familiar with the extent of the stakeholder involvement requirements that are in the current MHSA. Steve McNally, I see your hand up. You want to go ahead?
Yes. So I think everyone's pretty familiar with the CPP. I mean, Cal Voice did a great thing that a great presentation years ago in 19, and I think the OAC was the funder. But we don't really have any recourse. So I guess one question would be is, do we think legislators really understand that it's not being done? Or are they as indifferent as everyone else? And then the second thing is, I put a question in there. If it passes by majority, but not by 2/3, what happens to this SB 326? That's it.
So I'm going to answer the first question, and then I'm not sure if Claire, I think I might know the answer to the second, but Claire may know better than I do. So the first question is, do the legislators understand the importance and you know, the need to have stakeholder input and
No, do they understand that it's not being done?
that's not being done? Okay, I know my opinion is that no, they don't understand, but that it's not a priority.
Because I asked Director Bass directly about the 5%. Like, what would we do with SB 326 if we'd spent $100 million collectively for each of the last 5 years?
Mm-hmm.
And she was like confused whether I was talking about the 5% to the state or the 5% for community planning.
Yeah.
And so I don't know, my experience, and you all are much more engaged than I am, or longer than I am. My experience is that everyone has their own interpretation of everything, and no one really refers you back to the like, well, you guys do a great job of this, but most people, they rarely refer you back to the statute, the regulation, or the information notice that explains what to do. And so consequently, they misstate a lot of stuff, and they get away with it because people are just too busy. So anyway, I think maybe then making them aware of that's important. I thought Toby Ewing gave an opening to getting off the proposition kick by getting at the last hearing with the health committee to give them the opportunity to see it's more important to do this legislatively than it is as a hearing. Because Because it seems like so many people are, well, I don't know. I think it's going to happen anyway. But I mean, what can we do to at least, do something between now and then? So I guess the question again is, it doesn't pass, it passes with 50% or over 50%, but not 2/3. What would happen?
Claire, do you know the answer to that?
Yeah, Steve, it should be dead for this legislative cycle. So it would be just like any other bill that didn't pass. And I would have to educate myself slightly more. I know from lobbyist friends that because they chose to have the bill be an urgency, meaning it would take effect immediately and not January 1, that action alone would have required the legislature to pass it by 2/3. You could also probably say they might need to, due to some language in the MHSA. Either way, if they don't get enough votes, the bill's dead. It's not going on the March ballot. And again, just to level set for people who don't know, because the MHSA was passed by a ballot initiative and because of some of the language that was put in the statute, in order to make serious changes to it like this, it has to go back to the voters. The legislature can only make changes to the MHSA that are consistent with its original intent. And you saw that when they tried to do No Place Like Home in 2016 and spend some of the money on housing and spend it off the top of the fund. They tried to pass that just through the legislature. They got sued, and it was determined that they needed to actually take it back to the ballot for a change of that nature. So that would roughly be the setup here again, is if they don't get 2/3 vote in the legislature, this bill fails. It doesn't go on the March ballot. If they want to do this again in the future, it would have to go through the same process where the legislature would have to pass the language and it would go on the ballot. I hope that's clear.
It is, but the last thing too is that sometimes people say certain things that are changing have to be a ballot measure and certain things don't. So is it all or nothing, like you said? That's, I guess, the clarity.
Yeah, that's correct, Steve. I know you're getting us real into the nitty gritty, because I have looked at the bill for, if they pass this, what changes would take effect simply because they passed it by a 2/3 majority, and it's consistent with the MHSA versus, what all of what they have passed actually has to go on the ballot. It's a complicated question, but I will say, the stuff that they really want to do, like significantly change the funding allocations, expand to include substance use disorder, all that's so extensive that's got to go on the ballot. So I just don't see them being married to this in any way unless they're going for the whole thing and it's going on the ballot.
All right, thanks.
Thank you, Steve. Richard, you put your hand back up. I'm not sure if that was intentional or a mistake. You can go ahead though.
Yeah, I did. The thing is we all need to contact our state elected officials and educate them. My Senator John Laird is having his staff do an inquiry to my concerns so that he's educated the impact of SB 326. And I'm glad that I got his attention and to check into it. We need more state elected officials to be educated so that they can vote down what's coming. Secondly, contact your news media. Go to the newspaper. Do a letter to the editors. We got to make noise, because I'm afraid that this thing is going to pass since we don't have someone backing for funding the full page advertisement about these drastic changes, the power grab, political power grab of changing the MSHA to what they want to do. It's not okay, period.
Thank you so much, Richard. I totally agree. I'm going to move forward now because we have about a half an hour left, and I have probably at least 15 to 20 slides to get through. So I'm going to be powering through here. So part 3 is SB 326's changes to the MHSA stakeholder involvement mandates. So again, in the previous section, I kind of broke it down between state level stakeholder involvement mandates and local level stakeholder involvement mandates. And so I looked at it through the same lens regarding SB 326's changes. So major state level changes are sort of the quick and dirty overview. As you already know, it changes the name of the Mental Health Services Act to the Behavioral Health Services Act. It changes funding allocations for state administrative agencies from 5% of all MHSA revenues to now 10% of all BHSA revenues. It changes the name of the MHSOAC to the BHSOAC. It increases the BHSOAC size from 16 to 24 voting members, and also composition. It creates additional designated seats for consumers, family members, and providers, but not peers. Okay, so one of the themes I noticed throughout SB 326 is like there's no acknowledgement of peer support specialists or peer, throughout. There's no expansion of any existing language around peers, none of that. So it's almost like we're looking at, the same, it's almost like they're changing the same mental health system that existed before 2020 when the peer support certification program passed. It also identifies specific state level funding allocations and programmatic duties. Claire covered this in her updates for HCI, 3% for Behavioral Health Workforce Initiative, and Department of Public Health, 4% for population-based prevention. So we talked in the previous section about the MHSA's current requirements for state level stakeholder involvement. So what I did is sort of a side-by-side on the updates from the current MHSA to the proposed changes to the BHSA. So prior to making allocations to counties, statewide funds at 5% is reserved for these state agencies. Those administrative costs shall include funds to assist consumers and family members to ensure their appropriate state and county agencies give full consideration to concerns, blah, 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 right? So under the BHSA, this language remains mostly intact. It's moved to a different section in the welfare institution, or it's a different subsection within 5892, but it's still in there for the most part. So that stayed the same. Specific stakeholder involvement requirements for the Behavioral Health Services Oversight and Accountability Commission. So right now, as I mentioned sort of in the overview, the MHSA requires 16 voting members, and of those, there are 4 positions for consumers and family members. Now, under the BHSA, there's going to be 24 voting members, and it's going to include all of these different positions that are appointed by the governor. So 2 people who've had a mental health disorder, 2 who have had substance use, family members, et cetera, et cetera. And there's additional seats for other representatives of various behavioral health professions, but again, not peers. So the good news is there are more seats at the table. The unfortunate news is that there's not a seat for peers here. Again, additional requirements around stakeholder involvement for the BHSOAC. So in making appointments, the governor shall seek individuals who have had personal or family experience with mental illness. That language remains mostly the same in the BHSA. It just adds additional language around in making appointments, the governor shall seek individuals who have had personal or family experience with mental illness or substance use disorder. So there is some language here currently in the MHSA around what the MHSOAC is required to do. It shall, under 5846D, it shall ensure the perspectives and participation of diverse community members reflective of California populations and others suffering from severe mental illness and their families is a significant factor in all decisions and recommendations. That entire statutory language was repealed without a replacement. So there will no longer be a requirement that the BHSOAC ensure that the perspective of consumers, family members, and diverse communities are a factor in all decisions and recommendations. So that is not a good thing. For the most part, the requirements for the Planning Council and HCI in developing and implementing the state's 5-year MHSA wet plans, there was no statutory changes to this language in the BHSA or in SB 326. I think that some of this is inconsistent with the rest of the BHSA. So it looks like it might have been an oversight, but that'll be just between us and the 83 attendees at today's meeting. So don't tell anyone. So those are the major changes to state level stakeholder involvement requirements. Let's look at some of the major changes to the local level stakeholder involvement requirements. So major local level changes. So the good news is that the BHSA keeps most of the existing statutory language for stakeholder involvement. So it keeps that language. It might move it around into different code sections and the Welfare and Institution Code, but it keeps the core language. It mandates inclusion of additional stakeholder types. Again, not peers though. So here's where it gets a little bit dicey. So it changes the MHSA 3-year plan to an integrated plan for behavioral health services and outcomes. So instead of like a 3-year plan, it's called an integrated plan, which counties must develop every 3 years. So, you know, on the same timetable. However, unlike the MHSA 3-year plans, which apply only to MHSA programs and expenditures, the BHSA integrated plans apply to all behavioral health programs and expenditures at the county level. So not just those that are funded through the BHSA. So it includes behavioral health services that are delivered through Medi-Cal managed care plans and other county administered behavioral health services. However, stakeholder involvement, the requirements around stakeholder involvement only applies to the sections of the plan that have to do with the Behavioral Health Services Act programs and services. So the mandate is only for the BHSA programs and services part of the plan. The other area where it gets dicey is that it keeps the annual updates, and it also adds this option for counties to do intermittent updates, but it removes all stakeholder involvement requirements for annual and intermittent updates. So,
Can
go ahead.
Cut in with a comment there, Danielle? And I really care about this. They made it optional for there to be the stakeholder involvement for intermittent updates or annual updates. And, you know, one of the things that they added in when they amended is that the counties now have some supposed flexibility back to shuffle funding between one allocation and another, but they will do that in the intermittent, they can do that in the intermittent or annual update process. So, you know, if the county's going, okay, we want to be flexible, we think we don't really have that many unhoused people in our county, we really want to shift this more to FSPs or something, you know, the community would not have the ability to, there would be no mandate for the community to be involved in that process, which is a very important process of wiggling things around to be better serve local needs. Thanks for letting me cut in.
Yes. So you made really two good clarifying points. So thank you so much. So part of it is like, it doesn't say that consumers and family members and stakeholders can't be involved in the development of annual updates and intermittent updates. It's just not required. So for those of you who have been advocates for a long time, you know what that means. Read between the lines. And the other thing was that in providing additional flexibility in these most recent updates, it would make a lot of sense that you would need stakeholder feedback and input and involvement around how that flexibility should be maximized. And if you don't consult stakeholders, then you're not necessarily meeting community members' needs and all of that. So you're not going to have an effective outcome if you don't consult with the community, yet you can do it through a process where you don't have to consult with the community. So as a recap, this is what the current MHSA stakeholder involvement cycle looks like, right? Because remember, the MHSA is an annual ongoing stakeholder planning process. You have the actual community program planning process to develop the 3-year plan or the annual update, and it goes through local review and all of that, right? So this is what it currently looks like. This is an annual cycle. If you compare that to the Behavioral Health Services Act, this is more like a Ferris wheel now, actually, but you have this triennial stakeholder planning process, right? Where stakeholder involvement is only mandated when the counties are developing their 3-year integrated plans, Okay, so you have stakeholder involvement up here at the top when they're developing the integrated plans. And then you have some stakeholder involvement, when they're creating the draft and it goes through the local review process. But then for a year, even in the development of the draft annual, I didn't even include intermittent updates here, but in the drafting of the annual update #1, you don't have any stakeholder involvement in developing the annual update here. Stakeholders can get involved at the local review process, which is, the 30-day public comment period and the public hearing with the local mental health board. Again, no stakeholder involvement for another year until the draft annual update to the 3-year plan is developed and published, the next year. So it minimizes the level of mandatory stakeholder involvement, and it creates a longer cycle between when stakeholders need to be involved. The odd thing is it keeps the language around meaningful stakeholder involvement on, mental health policy, program planning, implementation, budget allocations. It keeps that language in the BHSA, but it doesn't provide a way to operationalize that when the planning process only happens every 3 years. So I don't see how stakeholders can be meaningfully involved in all aspects of local planning and decision-making and all of that when the functional process only happens once every 3 years. So some general, this is sort of going back to our original webinar where we sort of talked about what our main criticisms of SB 326 were. And these have carried forward even throughout the various amendments. So the big issue is that SB 326 was dropped on the public just over 2 months ago. It was drafted without any meaningful involvement of clients and consumers, peers, providers, and other key stakeholders. The legislature is jamming the bill through to get it on the March 2024 primary ballot, which limits opportunity for meaningful stakeholder involvement. And the legislature has not fully examined the potential impacts of this bill on existing county MHSA programs and the clients that they're serving. Other general criticisms that have carried forward since our first webinar: it eliminates funding for PEI individual services and CSS general system development. So it added back in that outreach and engagement. It permits funding to be used for outreach and engagement, but it still eliminates funding, or it no longer recognizes a category of services under the current MHSA under CSS general system development. Now general system development programs are currently providing crisis intervention and stabilization, peer support services that are not funded by Medi-Cal. So for all of the peers out there and peer-run agencies and programs that are not certified and don't want to become certified, this is where they are getting funded. Wellness centers are getting funded through CSS general system development. That category of funding goes away. And so if these services are not Medi-Cal billable, they will probably be eliminated. The general system development also funds services for traditionally and underserved communities and activities involving system transformation and client and family advocacy. And the main criticism, and this has been put forward by the Legislative Analyst's Office, well, they didn't say it in this exact way, but they've brought forward this particular criticism in that SB 326 enforces a top-down approach where the governor and the legislature are identifying priorities for California's diverse counties and communities. And by diversity, it's not just racial and ethnic and gender diversity. We're talking about rural and urban diversity and things like that. And there's a reason why local control is a big issue in California. It removes a lot of that flexibility that counties have and the communities have to come together and decide what to prioritize, because it instead shifts the focus to maximizing drawdown of matching funds, which the MHSA was never intended to do. So in our view, this top-down approach is more illness-centered, it's one size fits all, it's compliance-based, and it goes back to fail first, which increases stigma and makes it harder for people to get help in their communities. Some other observations about the changes to SB 326's changes to adult services standards. This information is in the PowerPoint later, but I moved it, I bumped it down because I knew we wouldn't have time to get into it. So this is sort of an overview. The changes in the language to adult services standards de-emphasize client voice, choice, and control over their own services. It replaces the MHSA's client-centered and recovery-focused approaches with professionally directed and illness-centered services, so sort of reverting back to the medical model. It expands involvement. So this is a big one for us, okay? So some of you here may not agree, but this is a big issue for Cal Voices. It expands the involvement of adult clients' family members in client services. So it codifies the concept of family-driven services for adults. We oppose this because we are supportive of the client being in the driver's seat for their own services. And as a result of expanding family involvement in adult services, peer support services and adult system of care might become, eventually primarily staffed by adult family members rather than consumers due to existing and re-emerging stigma, greater family involvement, and the loosely defined lived experience requirements for Medi-Cal peer support specialist certification. Some other observations around the stakeholder inclusion language changes in SB 326. So it sort of legitimizes this fig leaf approach to stakeholder involvement. So although most of the MHSA's existing statutory language mandating local stakeholder involvement remains unchanged, the elimination of the requirement to include stakeholders in development of annual and intermittent updates will erode the existing CPP process and marginalize key voices. So counties might be able to use these, as Claire kind of alluded to already, the counties may be able to use these intermittent updates to enact significant changes to their behavioral health plans without any stakeholder involvement whatsoever.
Yeah, and I'll make a comment there because I think Patricia Wetzel had a question on that, or wasn't sure. The way I read their language, they separately list each plan year, 2026 to 2027, 2027 to 2028 as a year in which the county could shift funds. So I don't think they can only do this fund shifting on a 3-year plan basis. I think that they could potentially do it in an intermittent or annual update, but it would then, that shift would then be stuck for the rest of the integrated plan year. But I think I mean, the way I read the language currently, I think they can do that funding allocation shift in an annual or intermittent update. And again, that would be our concern that, in that very important conversation of actually we need to change an allocation, that the community should be involved there.
And even if it's not, even if the intermittent update isn't used for that limited time flexibility that they've, written into the new amendments, even if it's just used to change existing services and programs where there is some flexibility to do so within the new BHSA, they can still do it without any stakeholder involvement, and they don't have to go out to the community and make their case for doing so. They don't have to show data as to why they've made that decision. They can just go ahead and do that. So that's problematic. And then counties are only required to, I mentioned this before, include stakeholders in the development of their BHSA programs and expenditures, not other services that are included in their integrated plans, their integrated behavioral health plans. So again, it's like kind of marginalizing where stakeholder involvement, is even required, lessening it and diluting the impact of stakeholder involvement. Let's see. In our view, by adding to the statute specific stakeholder groups that also must be included, that are mandatorily included in the local planning process, it waters down client and family voice and input. It does not mandate the inclusion of peers, advocates, or representatives of other. So they added this laundry list of other interests that need to be involved in stakeholder the planning process, but they didn't include peers, advocates, or representatives of traditionally marginalized communities. So it was a little bit odd that they went through the effort of adding all of these other interest groups, but not interest groups that have not interests that have been around forever and that are already underrepresented in decision making. Another issue that we observed is that the integrated plans workforce development goals that counties have to consider when they're developing their 3-year integrated plans now, they don't include any provisions to expand peer support services or to increase consumer employment. And one of the big issues that have been going on in California for decades, because I look at the SAMHSA data every year when it comes out about, you know, the employment rate of consumers who are receiving public behavioral health services, it's always between 9 and 11%. The latest data from 2021 of California's consumer employment rate is 10.7%. The rate of employment for consumers across the country is 24.6%. We're half. Our consumer employment rate is less than half of that for the rest of the nation. So at this point, I'm going to open it up to additional questions and discussion. As I mentioned, and I'll kind of just give you a quick preview. In here, I do a full assessment of more statutory changes, but I just knew that we weren't going to have time to get into all of this. So this will be included in the PowerPoint that we send out to everybody, but I didn't want to get into all the nitty gritty now. I wanted to give you more of an overview because we can really get bogged down with those changes and not talk about the key issues. So if anyone wants to go ahead and jump in or raise your hand or whatnot, now is the time. Richard, go ahead.
So as a person with lived experience and a former peer worker, you know, this is why I volunteer with Cal Voices, both Access California program and being a member of the California Association of Peer Professionals. This was my gut feeling that our peer community is totally not being respected as a professional, period. We need to raise our voices. It's now or never. And this is what I'm here for. Why invest 5,000 workers by CalMESA for Californians to have peer workers with the mental health community if they're not being included with the county workforce, with the county plans, with CalAIM? It's a big question mark. I'm fearful for our workforce.
Yeah, I think that's right. I think you have reason to be fearful. Mark, your hand is up again. Do you want to go ahead and add something? Okay, I'm sorry. I'm really confused because I always see your hand up and I don't know if you mean to or if you're having like technical difficulties or what the heck is going on. But I don't want to ignore you because I don't want to think it's a mistake and then you actually had something that you wanted to say. So I'm going to assume that you're not able to contribute something right now. Does anyone else want to provide comment, question, feedback? I'm sort of scrolling through the chat here. How is Cal Voices mobilizing on this? What is the strategy? Testimonies to the government. So we will be at the Capitol tomorrow. We've written letters. We've provided red line amendments to the legislature. It's really hard because there's a lot of different interest groups and everybody sort of has a different take on this. So we've been trying to work with other advocacy organizations to the extent that we can. We have a meeting later on this afternoon to try to express some of our concerns along with some other advocacy agencies to talk to representatives from the state about this in the governor's administration. We've been doing a lot as far as providing feedback to the legislature and providing recommended changes, but a lot of it is falling on deaf ears. And, you know, Claire, you might want to speak to that more because you really have been on the front lines as to, you've been up to your neck in all of this for weeks.
Yeah, I will say, part of the problem with them dropping this in a spot bill is that it had not, if they had not done that, if this had been done normally and the whole language had been released back in February, it would have gone through multiple committees in the legislature, and those committees would have each written an analysis of the bill. So part of the problem for the community is we had, a total text of 233 pages and no information from the administration on what was in it. And so if you wanted anything besides a 30-second take on what was there from, very brief PowerPoints from the administration, you had to go directly to the legal language, look at it, compare it to MHSA. And because we're one of the peer-run agencies that have attorneys on staff to do that, we took a lot of the, we did a lot of work to just tell the community what was in it, so far as we could tell. And do that, we prioritize that public education piece. And I think we did offer some amendments, and we had to do those very quickly. I mean, it was June 19th, they released this, they wanted any amendments by July 13th, and it's 233 pages. So we've been working really, really hard just to understand what's in it, tell the community. And so, we have done less on the organizing front. We've done as much as we can up until this point, but our service to the community has really been to tell them what's here, so that they can decide if they like it or don't like it, and have enough factual basis to go talk to their elected representatives and express their opinions about it. But yeah, we've been very busy just trying to do the basics.
Yeah, it feels like treading water, because it's just like we're just struggling to understand this, and we have legal training, so it's like we are trying to condense this and simplify it and get the information out there, but it takes a lot of work because there's a lot of cross-referencing to do. And so that's not to excuse the fact that we have not been as focused on the organizing itself, but it's the reality of the situation, as Claire described, when a bill of this magnitude gets dropped out of thin air, and then everybody's doing a mad dash and scramble just to understand what it means, let alone respond to it. It's been rough.
But I will say, when and I think there's many interest groups that have been doing advocacy up till this point, primarily to try to save their funding for the folks that they serve and their subpopulation within the MHSA that they're focused on. And, because this is coming from Newsom, this is not coming from the legislature. The amendments, we have been told, are being directly negotiated with Newsom. So, this really isn't a normal bill in that sense, in that there's probably a lot less influence of your elected representatives, unless they want to stand up and say no, than would typically happen. And also it means that smaller providers and advocacy agencies like ourselves, we don't have much of a seat at this table. Almost no one from the community has any seat at this table. And so, when the final language hits and it's a done deal, whether it's coming out of the legislature this cycle and going on the ballot, I'm sure that we will be in a better position to spend some time organizing the community as to, whether we want to tell the voters, please don't vote for this, we think it's terrible. But so there's lots of work to be done, and there will be a pause between September 14th, when the language is set, and March, when there's a vote on it.
Yeah, and obviously we would want to influence and tamp down the worst of it before then, but we're yelling into the void as far as we can tell. Once in a while, a little sentence gets through, but we're trying our best, and there is a plan in place, and we are not going to be able to derail this train. So I'm just trying to set reasonable expectations and let everybody know what's actually happening. Not to say that we should give up and not do anything about it. That's not what I'm saying. I'm just letting everybody know that the powers that be have decided that they want this bill to pass. And so they will, move heaven and earth to make sure that it happens. So our job right now is to make it less bad to the extent we can. Steve, you wanted to contribute?
Yes. I totally agree with Richard about the sense of urgency to empower the public. And what I've been on a lot of, I watched the OAC hearing. The business guy said, if this was my business, I'd tell you go back to the drawing boards. The chair said, no, it should not be a proposition. What I see is a lot of incredible siloed efforts. But what I don't see, well, Remco sort of did it because they're protecting all the smaller providers, are trying to. But at the California Department Behavioral Health Planning Council, a guy from one of the supervisor's offices says, well, we're going to lose all the outpatient services. And I never really heard that. And so the CEO in LA has gone on record, written a letter, but we haven't seen a copy of it. So I think it might be helpful to give people the questions that like if you go to a hearing at the state, there's usually questions that they have to answer, whether they actually do or not. So, for example, this is the state chasing Medicaid dollars. Not all Medicaid programs are appropriate for our very difficult community. So when was the last time for the activities that you're going to want to use Medicaid dollars and maximize them, which is already sort of in the plan? What is it that, so here's the activity or the program. Here's the last state Medi-Cal set a rate for it. What is the Medi-Cal rate? And if it varies by regions, just show us the range. What is the private rate for that, if it's even accepted by private insurance? And then what's the dollar difference and what's the percentage difference? Because if you're building something on an entire Medi-Cal reimbursement to a large degree, the counties haven't proven to be real successful at that. If you look at the annual revenue expenditure reports and look at the FFPs, federal funds participation. And for some reason, the state gets a pass for showing any details. And so I think if we were to give the legislators questions that they could forward, if they were so charged, they might see that I think people realize it's a stack of cards, but it might become more evident to them. And I'm just looking for a way to give them confidence to pass it, but not put it on a proposition. So not to get to 2/3. And I think as people start talking, until we as a group, Cal Voices, Remco, CBHDA, which was the last letter that I could find public, and I had to ask for it. Everyone else's letters were all included with Remco. And figure out, like, yeah, everybody wants SUD, but what is SUD without a funding source? Then they realize, well, we want to be included. So a lot of the behavioral task force people all went out in public and signed on with Newsom's press release, but nobody ever talked about the funding of it. So anyway, I think I'll stop belaboring it, but I think if you could give us questions, or you could ensure with us that you all are collectively working together rather than being picked off, because I think if our voices really mattered, we would have been spending $100 million for community planning. So our voices obviously don't matter. So now what do we got to do? So anyway, for what it's worth, thanks.
No, thank you so much, Steve. I want to just respond to a couple of the points that you made, because I feel like, I don't know how to say this, right? So I'm just going to come out and say it, right? So again, assume good intent and give me grace if you can. So the issue is, like, we're treating this like it's regular legislation. It's not regular legislation. There's a point behind this. The governor is going to run for president. California has this country's largest homeless problem, okay? This is a measure to say that the governor has done something to solve homelessness. Will it really? No, remember, I don't know if any of y'all watched, here, I'm gonna go off. Never mind. I probably shouldn't say what I was gonna say, but look, it is a ploy to make it look like the state is doing something to solve a political problem, but not really addressing the root of the political problem, which is economic in nature. Okay, so that's what's going on here. So you can come with all the logic and all the facts and all the data that you want. And it's not to say that we wouldn't do that, because that's what we do, because that's generally how these things are approached. But we're using regular tactics for a situation that it is not following the norm. Okay, because we can come with all the data and facts on our side, but it's not going to make a difference if this is a political maneuver.
Well,
And
I don't disagree, but I don't really think they presented a business case for this. And that's why the OAC business guy said, look, this is ridiculous.
though. But that's the thing. Like,
Well,
we
they don't
expect that
have-
they should play by the rules, but they are making up the rules as they go along because they're getting their orders from above them.
Right,
it's
but
and I
two
just wanna
co-equal
point
branches
out,
of the
Steve.
government, but it's not working that way.
right, but what
Sorry,
I want to
but there's-
point out that this is the problem with supermajorities. Nobody's willing to go against the governor. Every legislative aide we have talked to thinks this is a piece of crap. There's not anybody that knows anything about the legislative process that thinks this is a standard anybody should be looking up to. But nobody is willing to oppose the governor. So that's what we're really dealing with.
so
And all of these strategies, everything else, I mean, like, we can go on and on. We have spent endless hundreds of hours on this stuff. You know, none of us have taken vacations this summer. None of us are
no,
taking care of ourselves. That's how much we have been digging into this. But what I'm trying to say is, all we can do is keep stating the facts and doing what we're doing and educating the
Right.
public. But I mean, we're David up against Goliath.
Yeah,
what,
and,
what,
I mean,
what, hold on one second, just, and then I'll stop. But one of the first questions I asked at all the meetings that I've been in is, how are your board of directors involved for every provider in the state? In our county, Orange County, our providers don't even know this is going on for the most part.
Right.
And
Because they're
so-
too busy serving people like this.
Right.
They have
So
not
no,
made
I
it easy.
understand why, but somebody has to be able to bring their board of directors or somebody that has influence. Believe me, I'm not minimizing any of the stuff you do. I love what you do. And actually, you guys get sort of dinged for what you did sometimes, but I think people, that's fine. You're going to do it. But I just think we need to expand. We don't have the voice yet that matters to somebody. And until we find that voice, and that voice exists among us, and we haven't gotten them yet. So I'm not sure I guess I do this at a lot of meetings, is how are we going to empower the 40 million of us before, they title it any way they want, they put it on there. We know how propositions work in the state. So anyway, I just think whatever we can do, like I put a question there as Cal BHBC. I know who my elected is, but there are 59 board members that sign off on these plans. So some counties have been against it. Some counties are quietly against it. And some are meeting with our legislative delegations, but we don't know all 59 of them. So I can ensure that all 59 of them have this. Now I can go make that list. And I guess I will do it. I'll ask Teresa first, but at least then you can go up and stand up and say, hey, look, you need to have this, just like Care Court, it's not going to do what it was told it was going to do. It's pretty obvious. So no place like home, Toby's presentation. I know everybody's got different feelings about everybody. The one thing Toby has is he knows how to position stuff for people. So, and his little Hoover background gives him a little bit more credibility, I think, with people. So, but just making sure that people see it. I can't even get the people on my board to even look at most of this stuff. They're just not the right people. You know, they've been put on boards for a reason, not to be too engaged. And that's part of the problem. And I hate that families and loved ones are negotiating boys for lives. I mean, this isn't naming a park or naming a building. This is real stuff, real life stuff. So I'll stop venting. I'll save you from any more direct governor name call outs. But yeah, it's a very sad day, to be honest. It's just very sad.
Yeah, I'll just put some positivity back in it, and I put this in the chat. This is also special in that the voters have to approve it. And if you have read any of the press that has come out, California press, national press, everyone can do the math on it doesn't improve mental health services to cut services. So I don't know that this is such a done deal with the voters, because it is very easy to understand how problematic it is right on its face. So I although we really don't have much power within the legislature, that doesn't mean that, people of goodwill who are voting on this, if they are even a little bit informed as to what it is, will necessarily vote for it. It's been a lot of bad press. I'll just say that.
I saw Sylvia had her hand up and then took it down. But I also noticed that she was still on the meeting. So I've unmuted you, Sylvia, on my end, if you want to go ahead and jump in and add your comments or question.
Thank you. And I hope I'm not, off track on what I'm going to say, because I was popping in and out. But has anyone ever asked the governor why? I mean, because if it's coming directly from the governor's office, why are you doing this, and hold him accountable and his reasoning behind it? And then the other thing is, you mentioned local control. It's like local control has been coming down all the way around for years. I mean, from what I know, it started with Jerry Brown in the local control of special education. And I want to say it was 72 or 74. And then most recently, when he was in office, the local control funding formula for general education. And so they've been doing local control for some time now, and it's carrying through with Gavin Newsom. But the other thing that I have noticed, being a special education advocate and advocating for the voices for special education parents in our role in local control within the SELPAs, is once your voice gets so loud, then they create new laws to restrict your voice. And that's what happened with us in the community advisory committees. They completely redid it. They took us out of Brown Act, because once people get educated on how to use the laws to be able to strengthen their voice, now they want to take it away. So now we are no longer Brown Act committees, and they have given guidance that they've created without the input of community advisory committees for the community advisory committees, established by a group of people that they put in place without letting anybody know. And that's what's following through. So I see the same thing here now, being more active in mental health and being an advocate in the American Indian Alaskan Native community, and being active within the Department of Mental Health. It is when people's voices get loud and start holding people accountable to things that are written, and kind of almost creating it so that the work is stopping now, because we have this conflict. They're going to change the law, because the people who are at the head of these agencies are going to say, look, we need something to be able to continue the work. So that's what I see. And I don't know what the remedy is for that, because I never want to unstrengthen the voice of an advocate, because that's what I am. But I think it's responsible advocacy and collaboration. And sometimes that gets lost when there's animosity in relationships, people having bad experiences with these agencies, and then they're now advocating within them. It's hard to leave those feelings and those emotions at the door. It's hard to get from those emotions to advocacy. And I think that's a lot of the tension as well. So I think that it is possibly a contributing factor as to why the governor said, okay, I hear you guys, this is what I'm going to do so you can get the work done. Do you know what I mean? So that this is just what I'm thinking in my experience, but how to get around that so that people's voices don't get lost, and the advocates' role and strength within these agencies and within everything that's going on doesn't get lost. I don't know, but yeah, that's my input.
Thank you. Mark, let's try this again. Okay, so Mark put his hand down. Anyone else before we wrap this up? It's been a lot to absorb and a lot to go through, and I didn't even give you all the details on where all the information in the new statute. So we'll send that out to you with this PowerPoint. But I mean, I just want to go back to sort of what Steve brought up and how it is frustrating. Like, we feel like we all need to be doing something, and I don't discourage that, but it's just like, it is. There was a reason that this came out as a spot bill with absolutely no language in it back in February, and then language was not even added to the bill until June, right? So they were cooking all this up for months and months and months behind the scene. When they put that much work into it, when it's not a collaborative process, when it doesn't happen organically, from the ground up or within the legislature itself, and instead it's being directed from top down, there is a specific goal in mind, and there might be some movement around the margins, but there's not going to be real shifts and in all of this. So again, I don't want to be a downer, and we never know what's going to happen between now and September 14th when this has to pass the legislature, and between September and March when it has to go on the ballot. And I hope it's defeated, and I hope not more than a majority, or not more than 2/3 of the legislature will approve it. But I feel like the legislature is captured. It's captured right now by the governor, and they are going to do what he wants them to do, because his administration is writing this legislation and writing the amendments, and the legislature is just putting their name on it. So it's very frustrating. And we have been trying to work with other advocacy organizations and interest groups and all of that. And I think I don't know who said it. I think maybe it was Steve, but talked about beware of having different voices getting picked off throughout this. And that's so true, because there's we generally all agree that this is a bad bill. We don't want this to happen. But once in a while, someone will break through, and they'll be able to get, an amendment here or there that addresses their main constituency. And so then they'll withdraw their opposition. So that's, that's obviously a power play. That's a tactic that's used, and we're up against that as well. So
yeah, and can I just add to that,
yeah,
Dawn?
please.
Because I think that's exactly what happened with the children's providers, and we really supported all of their issues. And I understand that they, want to be building bridges with the administration. They got some compromises, and they were willing to take away their oppose. But I do agree with Steve that we should be building bridges with all of those communities, so we stand with one. I mean, so we stand unified and together, because it's sort of like this, pull up the ladder. We all should be lifting all boats, not just one boat of a marginalized community, but all boats. And, that's certainly the approach that Cal Voices is trying to take. Obviously, we're not perfect, and we'll leave people out. We don't mean to, but that's indeed what our goal is to try to represent the most significant issues for everyone.
And on that note, we've gone far beyond 1:30. So for those of you who stayed with us, I appreciate your time so much. We will be sending out, again, once we've downloaded the webinar recording, we're going to post it to YouTube. We'll send the link out to everybody. We'll send the PowerPoint slides out with the link and the chat log as well. I'm not sure if anyone, if there's more desire for future updates and webinars, like I don't know what's coming right now. And then the community program planning process was a topic that was specifically requested in previous webinars. So we addressed it.
I think we're gonna have to look at these 85 pages that just dropped last night.
Yeah.
That'll be next.
Yeah. And so I don't know if and when, or we probably will do future webinars, but I don't know. This is sort of the last in this first series. In the 1.0s. So we will stay in touch with all of you. You all are free to stay in touch with us, of course. We'll keep you informed to the extent that we can. Things are moving rapidly, and so we might not give you every update, but we'll do our best to keep everybody in the loop with all of these changes that are happening. And again, if you have any specific topics that you want us to cover in future information sessions, feel free to let us know. I appreciate all of you. Thank you.